Assalamu alaikum wa rahmatullahi wa barakatuh. We'll start the satellite symposium for AbbVie, the platinum sponsor. We will have two lectures in the satellite symposium today. We have two distinguished speakers. The first one is Professor Suzan Attar. She's a consultant rheumatologist. She's a professor of internal medicine and rheumatology at King Abdulaziz University Hospital. She got a lot of publication and a lot of work in rheumatology. And she's going to talk about guidelines, I think, of RA. The second speaker, Ziad Zahrani. Dr. Ziad is the director of rheumatology training program. He's an assistant professor at King Saud bin Abdulaziz University for health science. He got a master medical degree education as well as diploma in epidemiology and biostatistics. Just before starting, can you put the second slide? Second slide. We will have an online survey. So please be sure that you have an internet in your mobile. Okay. This is a Wi-Fi here in this hall. Then you will open the browser at http://slides.com. After that, you will enter the event code, which is RA Advanced. Then you can select Enter, Answer, and Tab. We'll have like a test now. Suppose there is a test. Can you, is it working with you? Okay. If not, we'll start with the lecture with Professor Suzan. Welcome, Dr. Suzan.
بسم الله والصلاة والسلام على رسول الله سيدنا محمد أشرف الأنبياء والمرسلين. First of all, I would like to thank the Saudi Society of Rheumatology for inviting me to present, and I would like to thank the Platinum Support AbbVie for asking me to present this excellent, hopefully, lecture. So what I'm going to talk about today is the RA treatment goals, the importance of achieving clinical remission, as well as the guidelines and the recommendation. Now, I'm going to go over the importance of the clinical remission, the patient-reported outcome, the factors affecting remission, including comorbidities, and finally, just a touch-up on the guidelines and the recommendation. Now, let's go over the history of rheumatoid arthritis, where we were and where do we stand up. We all know that the treatment of rheumatoid arthritis started within the early that using aspirin in addition to the gold therapy. It wasn't until the 1984 when three scientists won the Nobel Prize due to the discovery of the monoclonal antibodies at that time. That was followed by the evolution in rheumatology and the production of the DMARD agent, followed by the anti-TNF. Then in 2003, two scientists, they won the Lasker Award. Mark Flagman, in addition to Lavender Mani, they discovered the monoclonal antibodies as well as the anti-TNF. And since then, there have been a huge evolution in the formation of more biologic, more cytokine function, and the other pathways. Within the step-up regimen, because of the initiation of the comorbid illness, the request to achieve more remission, there have been a stepping down, but with one aim only to the patient, which is treatment to target and achieving the remission. So whenever we talk about a new medication, or whenever we want to evaluate an older drug, or even a study, we look at many points. First of all, we have the clinical indices, or to assess the disease activity, in the form of the ACR 20, 50, 70, or the DAS-28, as well as the CDI, the SDI, the radiographic score, which is the modified total sharp score, and the patient-reported outcome. So what is the patient-reported outcome? Dr. Hani Maalim, he spoke about it. Dr. Adiba, she mentioned it as well. It is what the patient actually feels in relation to the disease, which is RA, as well as the disease therapy. What's interesting about the patient-reported outcome, it is without the influence from either the patient or the nurse or any other healthcare provider. Now, what this is important, absolutely, it is important because it would help us and guide us what is the next step in treating the patient. If you look at the elder study or the older studies, since the 1990s, there have been a huge evolution as well as raise with the use of the patient-reported outcome, as well as the ICOM, which is the International Consortium for the Health Outcome Measure. They reported many patient-reported outcomes, about 10. And these are the 5 most important, which are pain, fatigue, activation limitation, overall emotional and physical health impact, and finally, the productivity of work. Now, the ICOM recommend that each of the 5 PROM domains are measured using a single tool. And believe it or not, neither the FDA or the EMA would approve any new study for any new drug if there wasn't any measure of the patient-reported outcome. Again, you should have at least one of each. Now, the majority of the one that we're using is the VAS. And actually, surprise, surprise, the VAS does measure the fatigue, does measure the pain, as well as does measure the overall emotional and physical health impact. As well as we have the HAC, which actually measure the activity limitation as well. And then there's the short version of the SF in addition to the European quality of life. So what's the importance of achieving the clinical remission in rheumatoid arthritis? Now, we keep mentioning again and again and again, the primary target for treatment of rheumatoid arthritis should be a state of clinical remission. Now, sometime you may accept a low disease activity in case you were not able to go into clinical remission. But why do we care so much about clinical remission? On the next couple of slides, I wish if everybody who would love to take out their mobile phone and screenshot. So first of all, achieving clinical remission improve the physical function and the work productivity. And this is a result from an Australian study, more than 300 patients between 2008 and 2009. And they were measuring the PROMs using the HAC, the SF36, in addition to the short version of the SF36 and the European quality of life and the work productivity. What I want you to look at is the green. The green represents remission, and the low disease activity represents the yellow. So it's very clear that the remission, that the patient in remission, they do better in the form of the PROMs in comparison to a good quality, which you consider that is the low disease activity. Now, this slide, perhaps our colleague from orthopedic surgery will not like, because achieving remission is associated with improved in the long-term outcome. And what's the long-term outcome that we all look at, or what we used to look at in the previous day, is the major orthopedic surgery. So 2 cohorts, in the 90s as well as in the 2000s, they used more than 2,000 early RA patients. They followed them up for 25 years, and they measured the DAS annually for about 5 years. And actually, the patients who were in remission, they required less incidence of orthopedic surgery. So what are the index-based measures for remission or RA? You all know it. MashaAllah, you're all expert, and perhaps some of you are more expert than me in assessing the disease activity in rheumatoid arthritis. So I'm just going to go over it briefly and tell you why do we have to look at them. First of all, we have the S-die, followed by the C-die. And actually, the key difference that both of them use the same formula, except in the C-die, the CRP is not included. Then there is the DAS, with the DAS28. The DAS28, we know it's a modified version of the DAS version. It has a stronger influence on the total joint score, more than the swollen joint count. And it has a high contribution to the acute phase reactant. Now, the DAS28 CRP is lower than the DAS28 ESR, and it evaluates the disease activity. Keep this in your mind for a second. So what are the index-based measures for remission? Remember, the previous slide, it was disease activity. And right now, we're talking about remission in rheumatoid arthritis. This slide was presented by Daniel Ali Taha in the ACR 2019, the 18. And he was talking about the measures to be used for remission in clinical practice on the left side, for clinical trials on the left side and clinical practice on the right side. The Boolean remission, which you should have less than 1, total joint, swollen joint, CRP, the patient global score, you have to have less than 1. So it's so restrict. And then the index base, which is the S-die. For clinical practice, you could use the Boolean remission, but the majority of us, we use the C-die. So where's the DAS? Where does the DAS lies over here? Now remember, when the DAS was created, it was mainly for disease activity. Patients with high to moderate disease activity, we used to use the DAS in them to assess the disease activity. So, but for remission-wise, the problem with the DAS, it's overestimate the remission. So what's the solution? With changing the cutoff point for the DAS, would this help the problem? And this have been proposed in the Annals of Rheumatic Disease in 2015. With changing the DAS-28 CRP from 2.8 to 1.9, would it make a difference? With changing the DAS-ESR from 2.8 to 2.2, would DAS make a remission? Actually, the answer in the next slide. It's very disappointing. So changing the cutoff point of the DAS-28, it doesn't make any difference, and it doesn't solve the solution. If you look at the patient agreement, if you examine to a 95 patient who are having the C-die, they will still have 1 swollen joint. In addition, for the DAS-28 CRP, if the 95 patient, they achieve a remission, they will still have 4 to 5 swollen joints. So the million real question, or dollar, let's say question, when do I consider my patient to be in remission? And that's what Dr. Ziad will talk about. Now, some of us will say perhaps patients who are having a low DAS score with no swollen joint, or some of you will say, I'm going to accept for about 5 joints. We'll see in a second. So the ACR Boolean remission, as I said, it's very restricted. It's very stringent. Total joint count less than 1. The swollen joint less than 1. CRP less than 1. The total patient score less than 1. It's so restricted, and it underestimates remission. Because of that, the last time it was used in the trial, it was back in 2011, and they haven't been using it since then, except when the JAK inhibitor started to come up. Then they started to use the Boolean remission again in order to assess the efficacy of the drug. The Boolean remission, which is a very restrict for assessing the remission, in clinical trials, if you ask anybody, how many patients do you have in your remission? In Boolean remission clinical trial, between 4 to 20%. But in clinical practice, it's 5 to 6% because it's very difficult to achieve as well as to measure. So let's go for the voting system. The first vote, please, carry your mobile. On a scale of 1 to 5, 5 being the highest, please rate the importance. Excuse me, فينك السؤال. شكرا. Please rate the importance of achieving your remission. Is it 5, very important, 4, 3, 2, 1? Excellent, that's an excellent, and hopefully we will get into that. Okay, good. Next voting question. In your day-to-day clinic, on what percentage of your patient are you able to measure? Again, it's to measure clinical remission. We're not talking about achieving clinical remission. So in 31%, they went to 40 to 60%. Okay, good. Next slide, please. Could we move on to the presentation? So what about comorbidities in rheumatoid arthritis? I was just talking to Dr. Khawla, Prof. Hani al-Muallim. Alhamdulillah, right now, because we have many guidelines and we're trying to achieve our own guidelines in order to achieve remission, we're going to the minor points. What may help us in order to put the patient into remission? And perhaps the next couple of slides will answer that question. What are the most common comorbidities in rheumatoid arthritis? In the prevalence of the comorbidity in more than 3,000 patients with rheumatoid arthritis, the Comora trial, which was a cross-sectional, observational, multi-center, international, it can't get better than that. So the most common comorbidity occurring in rheumatoid arthritis patients is depression, occurring in 20% of the patients. Now, we know what's a problem with depression. Number one, you cannot sleep. You're in pain. Your pain perception itself is higher than the normal population. None of the major RA disease indices for disease activity include a direct measurement of pain. Is that true? Yes. But if this is important, well, is evaluating the pain itself in rheumatoid arthritis patient after achieving remission is important? We'll see in a second. Now, we did mention that the Boolean remission, it's a very restrict with regard to having all the scores below 1. And even from all the 4 scores, if you have 3 in remission, but your pain perception is high and you're complaining, the patient complaining for pain, the reasons for near or missing remission, it's from the patient global assessment of pain in 61% of the patients. Now, when looking for the pain score, okay, on looking on the pain score, if it was 20, that will lead to the patient probability for having a PGA more than 1 is up to 90%. So the factors that the patient rate as essential for characteristic remission, when you ask a patient, not only the rheumatologist, they will tell you about the pain. So this is a message for all of us. Perhaps after the patient achieves our remission and they're still complaining from pain, we have to look for secondary causes of pain syndrome, such as fibromyalgia and other causes, before we decide on changing the biologic agent or a different cytokine mechanism. The residual unmet need for patients with rheumatoid arthritis, it's not only the remission part, it's not only the compliance to the medication, it's the pain perception and fatigue. So when we cannot talk about the remission without just achieving or mentioning some points about the guidelines and recommendation. The guidelines stated that we have to go into a state of clinical remission. Okay, we know that. And we have to go into something that we could apply on a daily practice. And they recommend that we have to mention it each time we have a conference or international campaign. There are more than 65 countries in which Saudi Arabia, with all the proud, we are over there. And there have been 10 recommendations since 2014. And they have been updated in 2016. And I'm just going to go over, I'm not going to go into the details of the treatment per se, but I'm going to mention the important points that we should consider in the daily practice. The target is sustained remission. Treat-to-target approach have to be applied. And we have to take into consideration the other comorbidities, the other aspects for the patient whenever the patient achieves remission. The take message over here that we go over 1 every 3 months. Initially, we follow up the patient until we achieve remission, and then we could freely follow up the patient every 6 months. So to summarize, achieving remission, it improves the physical function, work productivity, the long-term outcome. All the regulatory agencies right now, whether the FDA and the EMA, will not approve a single medication without looking at the PROMs, the patient-reported outcome. Pain unrelated to disease activity will affect the patient global, limit achievement of remission, and finally, all the guidelines, they recommend treat to target and to go over remission. Thank you so much for your attention.
Thank you.